Today I'm going to be covering a topic which we've covered before, and that is safe obstetric spinal anaesthesia. And this is a more concise synthesis of concepts we've covered before and which have come up in other talks, and specifically will address some of the issues in 2024. The Saving Mothers report, which came out just recently and covers the period of 3 years from 2020 to 2022, again looks at anaesthetic issues in South Africa, and the themes of the anaesthetic mortalities remain very similar to previous years. We're still doing spinals in patients that perhaps needed general anaesthetics. We still are not paying enough attention to high heart rates, either before we begin anaesthesia or in the intraoperative and postoperative phases. And there's still a delayed or insufficient response to hypotension under spinal anesthesia. And these themes will come up as I take you through this approach. Now, the outline that I like to teach is really to bring things back to basics, because it's often the basics that can change the course of the patient's journey. Firstly, prepare as well as you can, and that's often, it doesn't require much, but it's often a thing that's neglected in all settings. Think before you put in the spinal. Just before you're about to administer anesthesia, think, am I doing the right anesthetic for the right patient with the right people in the right setting? Do the basics right. Expect common complications. Be prepared for them. If you know that the patient is going to get a low blood pressure, you might as well be ready for that complication. Value the recovery period, which is often the last monitored period that we have in the district hospitals. So really use that period to make good and wise decisions for your patient. And remember that you can always ask for help, which is something that I think we sometimes neglect. So in preparation, you have to know your theatre. Now, you can either be the person overseeing it, or you can be someone who just works there. But regardless, you should know about this list, and I suggest you get this laminated and put up on the walls. This comes from the ESMOE guidelines, and that's all the anesthetic equipment that's required. Now, you can't check this every time you give an anesthetic, but someone in the hospital can be responsible for making sure these things are there, and that's worth paying attention to. When I walk into a theatre that someone else has set up or checked, there are 3 things I always look for. Do I have a working ambubag so that if my anesthetic machine fails, I'll be able to ventilate a patient? Do I have a reliable oxygen source? And I don't just rely on piped oxygen. You want a cylinder that's got oxygen in it in the theatre. And is there something that I'm going to be able to suction if I need it? And when you need to suction an airway, there's very little else that you can do except use the suction. So these 3 pieces of equipment, if you give me those, I feel I can manage most of the problems that occur when your equipment fails. In addition to knowing your theatre, you must know your patient. And I think sometimes we forget to stop and really examine our patients. Now, this doesn't have to take too long, especially in an emergency setting, but we should at least listen to the heart sounds. We should have a quick look at the airway, and we should look for either a ward hemoglobin or for pallor. And these are things we can do in every patient. And sometimes when we're multitasking, that slips through the cracks, and really this can often give us clues as to how things are going to go. And finally, use your monitors. Often we've got monitors that we don't put on patients, or we put the monitor on, but then we don't respond to what the monitor is telling us. So put them on and reflect on what they show you. It's so easy to do, and it's a thing that's often neglected. Remember to think before you put in the spinal. So just before you're about to administer anesthesia, there's a few questions that I think sometimes will tell you whether you're doing the right thing or not. Firstly, what's the indication for the Caesar? If the indication is placenta previa in a patient with 3 previous Caesars, are we not dealing with a placenta accreta, in which case spinal is probably not the right anesthetic? Is the patient coming because they're already hemorrhaging? These things sometimes give us clues, even if the patient looks stable now, as to what's going to happen in the future. Always look at the heart rate, and in particular the systolic blood pressure. And if that heart rate is higher than the systolic blood pressure, it's a warning sign. I also think heart rate on its own is very useful. When it's below 100, and that's reassuring. When it's between 100 and 120, you need to engage your brain and think, why is this patient tachycardic? They may still be okay for a spinal, but when it's over 120, you need to consult somebody senior. And I think that 120 is sort of a cutoff for where I become uncomfortable with spinal anesthetics being administered. What is your general impression? Does the patient look sick? Sometimes your gut is telling you there's something not right about this patient. Pay attention to that. And when you're not sure, get another doctor in the room if you can and say, what do you think? There's something not right about this patient. Often you have a feeling that things aren't right. And I just want to encourage you to pay attention to that. Are things likely to go wrong? I'm not expecting you to guess the future, but often the patient has multiple risk factors. And even though they look stable, if it's a grand multip who's got advanced maternal age, is coming for a Caesar, she's likely to have postpartum hemorrhage. She's likely to have uterine atony. So you can predict that these things are going to go wrong. So look for risk factors. And when you start stacking risk factors, prepare for these problems. And are there obvious contraindications, like hypotensive patients shouldn't get spinal anesthetics? Patients that are coagulopathic shouldn't get spinal anesthetics. So sometimes we just need to stop and think, is this the right patient for our setting, and are we giving the right anesthetic? There are 4 things that I always check as the patient comes through. The first is I look at that heart rate over systolic blood pressure, and I watch that not only before I give the anesthetic, but throughout the intraoperative period, into recovery, and even when I'm doing post-op visits in the ward. It's a very useful sign. I always check the hemoglobin, and that can be a ward hemoglobin. It doesn't have to be a full blood count. Not every patient needs a full blood count, but when the ward hemoglobin is above 10, I'm reassured. So when it's below 10, then I've got to start thinking again, but I do that ward hemoglobin in every patient. I always listen to heart sounds. 9 times out of 10, everything's fine, but every now and again you hear a loud murmur that will materially change what you do. So it's worth a quick listen to the heart sounds. And every patient should get their fluid status assessed. However you do that, you need to think, is this patient fluid replete, or are they dehydrated or hypovolemic? And spinal anesthesia is not tolerated well in a hypovolemic patient. So it really is a question you've got to actually ask yourself when you're examining, or you'll miss it. Now, doing the basics right really just means follow the essential steps that ESMO-E suggests. So for a start, you should know what sort of team you need. And we suggest a lead anaesthetist. That doesn't need to be the best anaesthetist in the hospital. It just means somebody overseeing what's in the theatre and what systems you have in place. You need to be able to do a GA in a spinal. You need to have an appropriate team for the whole Caesar, and you need to know when to refer. And to do that, these lists are available. Again, you can put them up on the theatre wall. They tell you what can be done at district level and what needs to be referred. Ruptured ectopics don't get referred because they're unstable. Obese patients should get referred, and the reason for that is that they have higher anesthetic complication rates, higher surgical complication rates, and the neonates also do worse. Now, when you have those patients that are having higher complication rates, they should be in settings where you're equipped and you've got the right staffing ratios to handle those complications. So you want to get them out of the hospital before those complications occur. Now, I know referral hospitals can't always take every patient just on these weight cutoffs, but it's worth asking the question. And remember that you only pick up difficult airways when you examine them, and patients that you feel you're not going to be able to intubate shouldn't actually get spinal anesthesia. They should be done in a referral hospital so that if the need to manage the airway comes up, you've got the equipment and the experience to do that. Now, this is the list of drugs required for anesthesia for cesarean section. Remember, this is not a memory contest. You can print these things out and put them on the wall, and it tells you exactly what you need and how to dilute it. Now, what I want to draw your attention to is that You need to draw up a vasopressor in every case. I don't think you always have to have both drawn up. I draw up phenylephrine routinely, and I have the ephedrine available in an unbroken amp. But you need to have something in a syringe that if the blood pressure drops, you can give it immediately. You mustn't faff around drawing up the drug. So have that drawn up in every single case that you do. In terms of doing the basics right, everyone gets a good intravenous line. And that means that it's at least an 18 gauge and that drip is running freely. It's worth investing in doing this properly before you start, because when you need to give those fluids, you don't have time to be looking for a good line. So a minimum of a green or an 18 gauge. Everyone has had hypovolemia actively excluded. You've got to think about it to pick it up. And everyone gets monitored. Don't get into the habit of just putting a SATS monitor on the patient, because when the blood pressure drops, you don't have a heart rate being monitored. And standard monitors are ECG, NIBP, SATS monitor, and everyone gets all of those things. And then remember that the response to anesthesia is important information. So when you put a spinal anesthetic in and the patient becomes very tachycardic, you learn things about the patient. You learn that they're hypovolemic or that they've got a cardiac issue. So watch how they respond to your anesthetic. It's actually particularly true in a general anesthetic. But even under spinal, when you see that very, very exaggerated response to your spinal, maybe you've missed something like hypovolemia or a cardiac lesion. So this is the protocol for cesarean section under spinal anesthesia. And I just want to draw your attention to a couple of things on this list. Firstly, it stresses that we assess fluid status, that you have good IV access, and that you give a preload of 500 mils. Now that preload is in the guidelines because the assumption we're making is that patients are a little bit behind in fluids. So if you've been running fluids in the ward intravenously, that becomes less relevant, but most patients come a little bit behind, and that's why we advise this 500 ml preload. So you give that while you're putting the spinal in. You do an NIBP every minute, so you cycle it at 1 minute intervals from the time that spinal is in. You can change it once the baby's out, the oxytocin's in, and the patient's stable to a 3 minute interval, but up until that point, every minute. Every patient gets 40% oxygen. Remember, this is for maternal reasons, not for neonatal reasons. So what we're concerned about is that if you do need to convert to general anesthesia, especially if you're in a hurry, 40% oxygen gives you double the time before the patient starts to desaturate. So it's buying you time in the event of an emergency, and we've advised that in all patients, even if the baby's not in fetal distress. And then remember that the pauses are built into the perioperative period. There's one before you start, and there's one before you cut. And both of these are opportunities for you just to stop and think, is everything done? Have I got everything in place? Have I remembered all the things I was supposed to remember? And the surgical safety checklist is not supposed to be a piece of paper that you fill in so that you are compliant at audits. It's supposed to change the culture of your theatre so that all of you are thinking, is everything ready? Have we got everything in place? Are we doing the right thing? Are the right people in the room? So embrace the pause and the surgical safety checklist. Use it to pick up the gaps. Get your spinal dose right. Co-load with 500 mils, so run it in after you put your spinal in. So try and get the full liter in by the time the baby's out. Don't forget to put a right hip wedge in. Still something we advise and we think is important. And check the block is working. Get used to checking the block on both sides, that it's working before you start. Just remember that the vials we get tranexamic acid in look like bupivacaine. They're similar size, often very similar labeling. Please go back to your theatres and find out where the tranexamic acid is stored. It needs to be readily available. You need to give it within a couple of minutes of when it's indicated, but it can be outside the theatre, just outside the theatre, somewhere like where you keep your succinylmethonium, or in the theatre in a sealed box. But make sure it's not on the spinal trolley. Make sure that it's not anywhere near the bupivacaine if it's on the drug trolley. And you need to be absolutely pedantic about this, because drug errors continue to happen in South Africa. And if you put tranexamic acid into a spinal instead of bupivacaine, it's almost certainly going to be a lethal drug error. So please make sure this doesn't happen anymore. It's an easy thing to fix if you remember to check what you're giving into the spinal anesthetic, and you help prevent that even getting anywhere near having to check just by having the drug far away from bupivacaine. So whatever system you can bring in, please do that. Another thing I'm going to be stressing this year is to remember that what we're interested in is the spinal column being flat, not the bed being flat. So if someone like this lady has steatopygia, she's lying on a flat bed, you'll notice the spinal column is actually head down. And if you put bupivacaine into a woman in this position, the hyperbaric bupivacaine is going to go towards the head, and you're going to get a high spinal. And I'm convinced it's factors like this that lead to high spinal much more than technique and dose. So in this patient, what you want to do is you want to come at the side of the bed, look at the spinal column, and in this patient she needs that bed head up so that the spinal column is flat. And you should do this in every patient. You should go and look at the side of the bed and see that your patient's not inadvertently head down. Also, you should put a pillow behind the head so that the neck is slightly flexed and the shoulders are slightly up, and that maybe causes a curvature to the spine, which also helps prevent high spinal. Expect common complications. If you know the patient's going to become hypotensive, you can prepare for it. This is data from our unit, and you'll see that we are treating hypotension aggressively. We're giving phenylephrine infusions and boluses. Half our patients drop their systolics below 100, a third below 90, and 20% below 80. So 1 in 5 are going to have severe spinal hypotension. And if it's that common, be prepared for it, either with a phenylephrine infusion or with boluses, but act quickly. And just to remind you, you should give the vasopressor if the blood pressure drops to below 90% of the baseline systolic blood pressure. And that's the systolic blood pressure you measured in theatre just before you started. So it's a high target. If the heart rate goes up by more than 20% after the spinal, give the vasopressor. If the patient's nauseous or vomiting, give the vasopressor. The number one cause of that when you're doing a Caesar is hypotension. If the patient becomes confused or drowsy, give the vasopressor. And if you aren't really sure, you think, should I, shouldn't I, then give it. We don't have a problem of too much vasopressor being given. We've got a problem of too little or too late a response. So give the vasopressor if you're not sure. There's negligible harm and so much benefit. And the reason that I keep banging on about this is if you look at what happens to hemodynamics, after you put a spinal in, the heart rate goes up, the blood pressure goes down. It happens in every patient that you put a spinal into. So just be prepared for it and act on it. Remember that not all hypotension is equal to high spinal. I spoke on this last month. You should go and have a look at this guideline. It's just 4 pages. But when you see hypotension and bradycardia, that's when you need to move quickly. That's when high spinal is in the mix. And in that situation, you still give the vasopressor first. So no matter what the cause of the hypotension is, give the vasopressor and then start to multitask. But when you see hypotension and high heart rates, that's probably just severe spinal hypotension. It also needs a fast response, but that is the far more common condition. This is a guideline worth reading. This is the Kinsella International Consensus Statement. It's an excellent panel of authors, and they take you through the mechanisms and the various treatment options, including options for phenylephrine infusions in resource-limited settings. And the South African lead on that was Prof. Dyer. It's an excellent document and it's well worth a read. And finally, value the recovery period. It's the last monitored phase that you have in district hospitals. So you've got the patient there on the monitors, you've got the time, spend it making wise decisions for your patient. So remember, not all patients require 40% oxygen. If they're still on oxygen and you can't get them off it, that's something to make you think what's going on. Monitor the blood pressure, the SATs. Make sure the patient's not bleeding, not in pain, that you've got oxytocin up. And I think in particular, look at that heart rate relative to the systolic blood pressure. If the heart rate's above the systolic blood pressure, you really need to think before you send that patient out. And if you think the patient's uterus is well contracted and they're not bleeding, and you decide to send out a patient to the ward whose heart rate is above the systolic blood pressure, schedule a post-operative visit. Go and see them at 2 hours after you've discharged them. Or make sure somebody does, because that's often a predictor for things are not as well as they may appear. And so if you use that approach, you prepare as well as you can, you pause whenever you can to think, am I doing the right thing? You do the basics right, you expect and prepare for common complications, and you value that recovery period. You're going to negate or minimize the complications that occur. And remember, throughout this approach, there's often opportunities to phone and ask for advice. So that can be an anaesthetist at another center, or it could be a more senior doctor within your own center. Use those pauses to share decision making whenever you can. And I think that this approach will see you through most district hospital level cesarean sections. And that's all. Thanks very much.